I am so excited that we are having another Shok Talk today. I'm Allison Shok.
I'm Richard Shok.
And we want to welcome Dr. Jack Perkins and Dr. Brian Meier, who are here to join us and have a conversation about cardiac health. And more specifically, in this conversation, we're talking about sudden cardiac arrest and CPR education in underserved populations. And we will get into what that means. But first, want to greet you guys and welcome you and thank you for coming.
Thank you very much for having us, Allison, Rich.
Yeah,
Appreciate
wonderful
it.
to be here.
We're so excited. So let's just start. Can you introduce yourselves? Tell us a little bit about yourselves and your background.
Sure, Brian, go ahead.
So I'm Brian Meier. I'm one of the ER physicians with Carilion Clinic, working mostly in Roanoke, but spent some time down in Franklin as well. We may get into some of this later. I have a background in global health in kind of through the research avenue, which is what brought me to partner with Jack and Perkins and Dr. and doing some of the research at some of their community events.
So cool.
Jack Perkins. I'm also an emergency medicine physician, and I work locally here at Roanoke Memorial Hospital, also at Franklin Memorial Hospital, and been in academics for roughly about 2 decades teaching. I started the Perkins and Dr. Foundation about 7.5 years ago, roughly. And in the past couple of years, we've changed our model. We'll get into that a little bit later. And we've built out a research arm to try to address some of the questions that remain unanswered, specifically with underserved populations. So thank you for the opportunity.
Oh, so glad to have you. Well, let's get into it. We're talking about cardiac arrest in different types of communities. Can you dive into that a little bit and explain what you guys have been kind of focusing on?
Yeah, so I'll let Brian start with that first, and then I'll hop in after that.
So I guess we'll get into more of the specifics of the logistics of it, but just it's known that cardiac arrest outcomes are different in different communities. I think that, it just intuitively makes sense for everybody. But I think it's the scale of it. So not only is there increased incidence of cardiac arrest in underserved populations, there's also decreased incidence of bystander CPR in these populations. So the one thing that might be able to help them in the minute isn't being done. And this, of course, leads to longer term outcomes, which, you could go down and down the line of economic outcomes and family outcomes and things like that. But that's kind of the genesis of where my interest came in, is trying to further investigate some of those things, especially locally here in Roanoke.
I think I'll answer that question from a foundation perspective and just in terms of lessons we learned over the years. So when we started back in 2017, we had one major goal in mind, and that was to have a single day per year that was free CPR and AED education for the public. And at the time, didn't truly understand what the barriers would be for the public. And we found out pretty quickly in terms of even if you offer free CPR and AED education, the fact that we didn't understand that the public needed to know why they needed this education. Why would they show up? And those facilities that hosted us were generally already familiar with CPR and AED education. And we were probably serving communities where they had other means to go get that CPR and AED education. The communities that we serve now are the ones that weren't showing up. And they would not go seek CPR and AED education because they didn't know they needed it. So if you think about it, it makes sense. So communities of color, those that English is not their first language, rural communities, those who have poor healthcare literacy, the list of barriers to equitable access to CPR and AED education is really long. Those are the communities we want to go to. And those are the communities that have worse survival for a number of reasons. One, because they don't have the same penetration of CPR and AED education. They don't have as many public access AEDs. And their learners aren't going to be as comfortable using those AEDs and likely would never reach out to go try to obtain them. So if you think about it, this makes sense in terms of if you go back decades and think about the model of CPR education that's been used, and to nobody's fault, but just not understanding that if you take cookie cutter education, the same educational platform, and take it to the entire country, you're not going to reach individual populations. you have not tailored that to those that don't speak English or that just arrived in this country or a community of color. And you're in a public forum, so those learners may not be comfortable asking specific questions for their community that they would like addressed. So really what we are doing is now acknowledging that there are barriers and trying to address them in a very different fashion.
With the 2022 study that came out in the New England Journal of Medicine, Garcia published findings that we know that roughly 45% of the population receives bystander-initiated CPR, but we know persons of color tend to be about 15% less than their white counterparts. We know that also there was a study back in 2015, I believe, also in the New England Journal, that addressed really the same disparities between bystander CPR in people of color. What sort of things have changed, like since 2015 through 2022, between those two studies coming out that have resulted in us not really like changing that metric, not making any success?
So again, I'll go back to answering that from just from a foundation that is also familiar with other nonprofits in the cardiac arrest education arena. It is really difficult to engage populations that don't know why they need this education. So it is very important to go into those communities, and there's not a lot of models out there of how do you go into a community. Let's say, for example, that the community you're trying to teach is Spanish language learners. We'll take Roanoke, for example. We have 8% of the city is Spanish speaking, so roughly 8,000 individuals, largely from Central America. And so, number one, a lot of them aren't familiar with the US 911 system. Number two, many of them have not had prior CPR or AED training or wouldn't know what to do in a cardiac arrest situation, and they have more barriers in terms of just calling 911 if they have fear of the police responding to their home. Well, how do you engage that community if they're going to have fear? And maybe they're concerned that we are a government agency and we want their information and are going to share it. So you got to earn the trust of that community. So really community-specific education is what we're designing. And unfortunately, I haven't seen a ton out there that is trying to address that. So what I have seen, and I think this is encouraging, is more literature highlighting the problem and saying that there are discrepancies in cardiac arrest survival in just about every community that is not of means and is non-white. That it's not really, and certainly that doesn't speak English as their first language. So I think in the past couple of years, we've seen a lot of new literature, and hopefully there will be a lot of avenues towards addressing this. And I think our model is one possible way to do that. But I think, unfortunately, we're looking at years down the road before we start seeing the needle change.
Now, CPR education is one big element of cardiac arrest survival, as is access to defibrillation. What sort of methods or strategies are being used to get defibrillators into communities that may not otherwise have them?
Great question. So let me go back and mention a little bit more about two things. Number one, if you look at recent literature, and this really hasn't changed. So going back to about 20 years ago when the FDA said defibrillators are for public use, right? That's wonderful for the FDA to say. It's an entirely different thing to empower the public to feel like that is something that I should be using in cardiac arrest and I feel comfortable using it. A lot of traditional models of CPR education don't always incorporate AED trainers, which takes away that learner barrier of, I've seen this, I'm familiar with it, I'm comfortable taking it off the wall. So not surprisingly, looking at the literature, whether it's in this country or others, public access AED use is largely less than 5% in cardiac arrest. The opportunity, and this is one of why isn't the needle moving? Well, we're not having public access AED use in large sections of the country and the world. So number one, getting individuals that are learners comfortable with using AEDs and getting AEDs into communities that aren't having access to them with money or funding. So our model couple of years ago, when we realized that we weren't getting the learners that we wanted engaged at our events, we changed our model. So it became using an AED as an incentive for that learner community, going to that community, whether it's a church or a small nonprofit or whatever that community, or Spanish language learners in a community center, going to that community, teaching them where they're comfortable with their peers, and delivering a grant-funded AED that they may never ask for or have the money for, is one way to go into that community. And then bringing other community leaders there so they see what our foundation can deliver to that learner community, and then having word of mouth spread that. So I think that's one way to deliver AEDs, and importantly, make those learners comfortable taking it off the wall and saving a life.
You guys both, I know, have backgrounds. You mentioned you have a global health background, and I know, Jack, you've spent time abroad, practicing medicine. Do you guys have any observations that might be interesting about what you're seeing globally versus what happens here, and lessons that can be learned?
I mean, I think a lot of the challenges are the same, regardless of community. I think Jack touched on probably the biggest one, which is just access. So going to these communities rather than having them come to you. If you think about just access of how do you sign up for a CPR class? Well, generally you go online, you search, and then you come back to it. Do you have internet access? Is this something that everyone can do? So access is a huge issue everywhere. I know in a lot of places that are less resourced around the world where I've spent some time, this is like 3, 4, 5 steps ahead of where they are. One of the groups I worked with would always talk about they were brought into Uganda to say, like, how can we help bring some of this stuff that you guys are doing in the U.S. with, emergency response and things like that. And they spent weeks and months there, and their response in the end was like, you could have your police officers carry gloves and something else to keep their car clean, because they're the only ones that are going to be on the scene, and they're not doing some of these things because they're afraid of getting their car covered with blood. But like, they were thinking, oh, how do we get ambulances? And they're like, no, you need to start with like gloves and access. So there's so many different things, and I think that's where we're trying to not take for granted some of the steps that we already have, to go back to kind of what you were talking about of, like, have we even asked the right questions as far as why we haven't been moving the needle?
You both mentioned your emergency room physicians. How does that translate to you when you're working in the hospital? Have you guys seen examples of how that barrier of understanding of how the U.S. health system works, does that become an actual practical event for you guys?
So I'll take the first crack at this. So the emergency department is a beautiful place to practice medicine, because you see everybody as they walk in the door as just a human that's in need. And sometimes they have a life-saving medical procedure that needs to be done for them. And sometimes the emergency department's a safe haven for them because of domestic violence, or they are unhoused, or alcohol addiction, opioid addiction, mental health disorders. So we see everybody. And over the years, we have become more comfortable with identifying social determinants of health, and really trying to look at each individual and see, like, how can we better deliver health care, not only access, but education to this individual in front of me, and realizing that it's very individualized. That person who is unhoused, their needs are different than somebody who's a refugee in this country, and their major need is understanding the U.S. healthcare system. How do they access primary care? How do they access dentistry, social work, all of these pieces that we see them in the emergency department, and understand that there's been some loophole that they've fallen through, and we're trying to address that. It's really a beautiful aspect of our job, of looking at a person and saying, like, how can I help them today, and understand that it may not be a life-saving medical procedure, but it could be a life-changing intervention that you're providing and helping that person with healthcare education. And that's, for me, where this started. So when I started the Perkins and Dr Foundation, it was out of frustration as an emergency medicine physician. we really only have 2 roles in the emergency department. And those roles are, number one, somebody has delivered bystander CPR and used an AED in public, and we are seeing that person after return of spontaneous circulation. And we are taking that victim of cardiac arrest to the next phase, whether that's to the cardiac catheterization laboratory, whatever caused their cardiac arrest. They've had a good outcome, but we had nothing to do with it. It's the public that gets the credit for that. Or the far more likely scenario, that we are left in the position of chatting with the family and informing them that their loved one has died, and we have nothing to do with the outcome because we weren't there, and thinking you can only have so many of these conversations before you want to go and do something and empower the public and change outcomes. This is one of those opportunities, but it parallels beautifully with the social determinants of health we see in the emergency department with cardiac arrest. It's like this is all looking at different individual populations. And so what we do now in the emergency department is saying, like, what are this individual's barriers to better healthcare outcomes? We look at learners for CPR and AED education. What is it that we need to deliver to this learner population that will empower them to start saving lives in their community and is going to get them to say, why don't we have AEDs in our community? Why do they only have AEDs in the zip code next to us? You know, what is it? How do we get funding here? And how are we really going to change outcomes? But the other piece is, and this is the broader goal of the Perkins and Shok Foundation, is to be part of healthcare education and delivery to underserved populations. So we would love to partner with other organizations, say this is a population that also needs educational financial literacy or opioid education or alcohol use disorder. We can deliver other aspects of education to that learner community because we know that they're a vulnerable population that doesn't have access to good healthcare education.
And I think being in the emergency department, one of our colleagues often uses the phrase, it used to be the emergency department used to be the front door to the hospital is what people refer to, but as our system has become what it is, it's kind of now the front door to the healthcare system as a whole. And kind of continuing with the access thing, this might be the only chance that a healthcare professional is going to get to interact with someone who's needed help for years and is going to need help for years to come, you know, hopefully so they don't down the road have a cardiac arrest, make them feel welcome into the system, you know, because I think oftentimes the medical system is, you know, ominous for people, especially if you don't speak the language or you're not from here, of like, well, you know, that's not for me. But to take that time, figure out their acute medical need, but then I think the great thing locally here has been the growth of the supportive services we have. So case managers, social workers, clinical referral coordinators of say, okay, like you're a part of this system too. This system isn't built for them, it's built for all of us. And sometimes it's literally 10 minutes when they're here for, you know, maybe their gallbladder's going bad or something, and this is the opportunity you get to say, like, we're here to serve you as well, so that hopefully then they re-engage down the road.
Oh, it's just making me reflect. I recently had a situation where I was with somebody, and I'm a nurse. I worked in the hospital for 10 years, but when a certain situation came up, I didn't actually know the best place to direct them or what advice to give them. And I am somebody that should be as well-versed as probably 95% of the population because I'm a part of it. And so, yeah, that makes a really just beautiful point that, again, I've never worked ED. I've done inpatient. I did oncology and pediatrics. But, yeah, this is the opportunity for them. Like, that's a huge step that they've made to walk through your doors. So to be able to say, we are a place that you can land safely and we can help push you in the right direction is just, I'm just reflecting on it. That's really a really beautiful way to think about the ED.
Also, the thought about the ED and patients coming in with cardiac arrest and having nothing done prior to arriving to the emergency department doesn't really give you very much to work with. And the same case is true, my background in EMS as well as working in the emergency department in South Carolina. When EMS arrives on scene 6 to 7, 10 minutes later after the cardiac arrest has happened and no one has done anything. I mentioned before the 45% number of people that received bystander-initiated CPR prior to EMS arrival is such a small number, and we can really be doing so much better. And I think it's really those getting around those obstacles of fear that people have when they encounter somebody that is in cardiac arrest. Am I going to hurt them? Do they really need this treatment? Somebody else will do it. Am I going to get sued? All these barriers that come up that really prevent them from getting in and acting are things that we have to overcome with education and with making them confident and practicing, and not just the one time that they get CPR training in high school 30 years ago, but getting them to actually get hands-on mannequin and practice and learn and have this experience once every year, once every couple years, so that they can gain that confidence and be able to do something.
So a perfect segue, so I can mention a little bit of the nuances about the education that we deliver. So when we constructed the Perkins and Dr Foundation educational model, the first thing we wanted to do was separate it from existing models out there. So we never certify any of our learners, and very specifically because there are plenty of platforms for professionals or anybody who needs certification. What we want is the public, bystanders, because their barriers to bystander CPR and using an AED are going to be different. So when we constructed our educational model, and we use 20 minutes of didactics, and while people don't like sitting in lecture, it's really important. You have to talk to the learners and say, you can't just tell them you don't do mouth-to-mouth anymore. You got to explain it. That doesn't make sense. You're going to have to go over, like, why don't we do mouth-to-mouth? Why can't you be sued? Why are you going to break ribs when you start doing CPR? What is an AED? Why is it not possible to hurt somebody with this? Every one of those, the American public, or really anywhere in the world, they're thinking about sitting there as a learner. And a lot of this comes from incorrect information in the media, movies, television, newspapers, using the term heart attack instead of cardiac arrest. They have wildly inflated survival statistics. So you're undoing a lot of this for the public and then reinforcing it with the hands-on education that we provide. But importantly, saying, like, taking that to the next level and tailoring it to that learner community. So if they are new to this country, we incorporate some education about what is the US 911 system. If they're in a rural community, giving them statistics specifically about what's the response time for EMS to get to your house. Well, if it's 20 minutes, you want the learner to think about that. And let's say it's an African American community, and that and it's rural, and that first person that's going to be at their house with an AED is the police officer. Is that going to be a barrier? Well, past 10 years, it's a very important discussion point. And going to that community and saying, law enforcement is part of the 911 system, and your loved one's chance of survival is diminished if you don't pick up that phone immediately. But also understand it could be a police officer, a sheriff's deputy with an AED in the back of their vehicle that's going to save your loved one's life. And you can't try to avoid engaging the police at the expense of your loved one's health. But that's important education that we feel needs to be imparted to our learners.
I'm sure you've had discourse in these classes that help, direct that, those conversations. I'm curious, Brian, you're actually doing research around those particular subjects, yes?
Yeah. And it's interesting to hear you kind of rattled off the list of all these barriers that we think about. And that's exactly, I think what we're finding. And so the question then is, in any particular community, what are the ubiquitous barriers that you must address in every class? And then what are more community specific that says, well, when we're with this group, we need to spend a little bit more time over here. And when we're with that group, well, that's pretty well known, but they have this other concern. And so just teasing that out so it's not a one-size-fits-all class.
So can you give a little bit more explanation of like how you're conducting your research and what?
Yeah. So I mean, it's pretty, simple stuff. It's been based off of what other groups have done in other cities and then tailored to us. Right now, it's mostly simply surveys. So using the training sessions as convenient samples of asking those specific questions so you can quantify it, right? So we do a survey that we've kind of iterated over the years, looking at first it was a little bit grander of cardiac arrest and some larger things. And then we figured out that we're actually missing like the granular details that actually would affect us in the class and day to day. So we've since scaled it back a little bit, simplified it to say, what is your experience with CPR class? Have you had one at all? What do you know about AEDs? What do you know about the 911 system? And I think that was probably a year, 18 months ago, where we started seeing the concerns about the 911 system being taken for granted. I always kind of use the joke of, if you take a BLS class, one of the first steps is like, can you go call 911 and get me an AED? And then you move on to what you're actually there for, which is, everything else. But for a lot of communities, that first step is like, that's it. I don't know how to do that. Or I have these reasons that I don't want to do that. And then what are those reasons, and how do we spend more time on things like that? So right now it's just surveys. And then we've started getting into, and in the long term, more qualitative data on that as well. So focus groups, structured interviews to say, this is what we're finding in this community or all communities on some of this survey data. Like, tell me more about that. Tell me more about your actual experience with the 911 system, so that we can get some more personal details and kind of anecdotes of people's actual lived experience rather than just numbers.
And you said that there's other communities in the U.S. conducting similar research?
Yeah, so we actually just had a meeting right before this, actually. So we have partners in Houston, San Diego, St. Louis, Baltimore, Richmond, and there's always new ones kind of popping up all over, and you could probably even name some more. So we bring them in. First and foremost, the training is kind of the issue, and I'm separate from that. So I let Jack and his group kind of handle that. And then I come in and say, hey, like, once you've established that you can hold training in your community, would you be interested in kind of adding this new piece on top of it and helping us out with that? And so, yeah, all over the country. And then it's nice because then it allows us to describe, well, here what we're seeing in Roanoke between this community, whether it's language or socioeconomic status, and are those barriers that we're finding in, say, the Spanish-speaking community in Roanoke similar to Spanish-speaking community in Houston or San Diego, where, like, conceivably, obviously it's bigger cities, but much more Spanish-speaking population, you would assume that the infrastructure is built up to handle that. Is it? Are there unique barriers to them that are different than ours here? And comparing some of those things.
Are you guys far enough along to be able to start making correlations or comparisons between?
A little bit, but there's been some hurdles just with being allowed to share the data. So a lot of it is, what we're finding is that most of it is the same, and I think it's on us to figure out those few percentage that are unique to each community and actually figure those out, because it's easier said than done sometimes.
Oh.
If I could add something that's pairs well with Brian's research team and our educational model. So because we don't provide certification, we use a really broad instructor team. And our instructors just are required to have taken a CPR class before, and we up-train them with train-the-trainer modules online. Therefore, we use a lot of students. And so the nice part is of attracting students, whether they are undergrads, med students, nursing, physician assistants, law, it doesn't matter. We even use juniors and seniors in high school. The aspect of engaging in research and looking at barriers in their own community is something that is why this research consortium is growing, because we're finding students are really excited not only for their own CV building, but also like, this is our community, this is different, we want to know how to do better. It's one thing teaching CPR, it's a completely different thing going into community that would never otherwise have that education and understanding their own barriers to that education. So I think this is why so far this is growing quite quickly.
And I can share some of the local findings that we're seeing. So probably the two biggest unique barriers to training classes in general in English and non-English speaking. Everybody worries about convenience. Like, are you coming to me, or are you making me go somewhere where I need to go? The unique ones in the non-English speaking community really seem to be cost and qualifications, which is something I think that surprised me. Of, you think you need to be qualified going into the class to even take the class, which I think goes back to, you're talking about AEDs before, of these are for public use, but I think that is taken for granted in a lot of places, that's for the medical people once they arrive, and like, no, it's for you until the medical people arrive. So those are probably the two biggest things that are unique in our community between English and non-English speaking communities.
Can I ask, are you guys, you both seem to be native English speakers. How are you delivering this education to those who are not native English speakers?
It's a great question, Allison. So for the past couple of years, we've had Jennifer Herrio Trejo as one of our board members, and she is leading quite well, I might add, our Spanish language education and outreach. This summer, actually, we had our first trial with a Spanish language education outreach intern at University of Virginia, hoping that we can expand this outreach because it is really challenging. So Jennifer and her team have built out an entire Spanish language curriculum that is using some of the data we're collecting to how do we best deliver a tailored educational model. So for example, one of the things that we did in the past, and I think just goes to like individualizing it, we had gone to a church in the past that was largely for Spanish speaking parishioners and actually given our educational module to the pastor and said, what is it your learners need to, this is before the research was formalized, this was kind of the same thing. What is it they need to hear that we can bring there? And Jennifer and her team are doing this. It's tricky when it's not in-person conversations outside of Southwest Virginia, but we have done this not only in Spanish, but we've taught in American Sign Language, Dari, Pashto, a number of other languages, and really it's getting community members who are embedded in that community willing to translate for us and provide community-specific education. So I think this goes to something we can talk a little bit later, but where are we headed? And one of those things of where we're headed is tailored education for not only language-specific, but community-specific, rural, urban, different communities of color. So templates could be on our website and accessible anywhere in the world for this is education that you want to provide, and here's a model that you can use as just, you can build it out for your own purposes wherever you might be, thinking about the community that you're educating and how to reach them and connect.
I've been a volunteer with the Compress and Shock, and obviously this is a thing that I live day to day, but my brain is just kind of racing, kind of hearing some of y'all's explanations and just getting a little bit more granular about how you're approaching those communities in a way that feels true to them and understandable and comfortable and approachable. And it's clear that you guys are really taking that into consideration to bring this education, because we can say push hard, push fast all we want, but unless people feel like it's being literally spoken in their own language, it might feel inaccessible. So you guys are talking about the future, so let's hear. What are your brains, thinking for the future? What's your hopes?
So a decade or two down the line, I would love to see state and federal legislation taking public health dollars and investing upfront in cardiac arrest. So, and just asking the question of, if we saved, let me rephrase, if we move the needle from less than 10% to somewhere closer to 20%, how much money would we have to invest up front in education and AEDs to put that many more survivors back in the tax base, and this actually pays for itself? Ask the question, how many less victims who are neurologically devastated would not need long-term care because they did not get bystander CPR or early use of an out-of-hospital AED? And maybe this is money well invested that is going to be changing the landscape of cardiac arrest around the world. That's where I see this headed. We're not there yet because it's going to take a long time for those discussions to take place. Where we are headed in the short term is taking our education, where this started in Southwest Virginia, from a foundation standpoint, and building communities so we can have Compress and Shock Foundation education anywhere in the country, in any community, in any language, and really start tailoring it to those communities, going after more grant funding, so that, because what we provide is the educational template, either direct help with the AED grant funding itself, or connecting with that community to get that AED, and then connecting with the local team there to say, we're building something here. We want the instructors to be local. We want the equipment to be sourced locally, so you're inspired by this and want to build it out from that network. So that's where we see this headed as a foundation, and using Brian's team's research to really construct the education so we understand how to engage those communities and eventually start understanding what else they need. So I will tell you that we also see this as the centerpiece of like a health fair education. We've done this a couple times, and the most successful one we ever did was right here in Southwest Virginia. So we went to Iglesia La Roca, which is a largely Spanish-speaking parishioner community, and we brought bilingual education. I gave the English education. My colleague Charles, who's also working with Brian on some of the research, is deliver the Spanish language education. And then afterwards, we had the health fair, 12 vendors. Our learners just went simply over there and access maternal fetal education, diabetic education, smoking cessation, primary care, dental care. It was really wonderful. And our hospital system was involved in this as well. This is something we could deliver everywhere because these are vulnerable populations that are coming together for CPR education, but there's so many more things we can do because now they're going to start asking questions about their cardiovascular health. Now they're going to start thinking about smoking and exercise and nutrition and accessing their primary care doctor, and we want those to be able to deliver that to them as well because we see this as one of many ways to impact outcomes.
And then I think from the research angle, kind of touched on it before, obviously growing out the national footprint of both the quantitative and qualitative aspects of it. I think our push in the near term for the next year is to really get the qualitative component up and running, because I think that's just going to open up all sorts of new questions once you sit in a room with 6 people and just hear their life stories and more than just a number on a survey, and figure out, okay, what are the next questions to ask? And so I think for us, that's kind of both the near and then the short term is following that thread wherever it takes us.
There's been a lot of really great research that's been coming out in the resuscitation science field. What would be your favorite or like most anticipated study that's coming out? For me, it's the race cars study out of North Carolina, where they're using intervention counties and control counties to basically look at what sort of aspects from a broad sense affect cardiac arrest survival.
So for me, I mean, I guess mine is less the actual resuscitation and more the public health aspect of it. So touching on some of Jack's aspects of, I know people have looked at in the process of looking at, well, does increasing CPR and AED education in a community, what does it take to actually then affect the outcomes? And people are starting to try to quantify that of this model that we're doing, whether it's through AHA or through other nonprofits. We can spend all the money we want in the world on having more classes. Does that make a difference in outcomes? Or do we need to, and for me, I keep coming back to the same thing of not taking it for granted, or do we need to rethink where we're putting all those dollars? Because it's great. I mean, more classes, more access is amazing, but what is the ultimate goal?
I'll answer that a little bit different way. So one of the things that we are going to do is start leaving a section for every community, whether it's California, Texas, Washington, Southwest Virginia, urban or rural, in that for 1 or 2 slides on your data, that learner community's data. So this is where the CARES network comes in, and we are hoping to collaborate in terms of we're bringing education to your community in this CARES region. Could you send us the data for this community? We're presenting it to them. They are rural. We want the EMS response times. We want survival to discharge neurologically intact for this community. And it really needs to hit home and be individualized. That's the data we're going to present them. If you just present them data that says, hey, you have a 1 in 10 chance of surviving cardiac arrest, that it's just a number. You got to personalize it. You got to have them understand, oh, by the way, you live in a city? Okay, well, now your loved one had a cardiac arrest during rush hour. Now your EMS time is 20 minutes. Now what are you going to do? Now where's the nearest AED? Did you realize it's around the corner? Do you feel comfortable taking it off the wall? This is where we're headed, and using some of that data to really address the individual learners that we're teaching.
I think CARES is just a really phenomenal research. I'm glad that you brought that up, and I was really pleased to hear that they received congressional funding to be able to expand that over the next few years to have a much larger catchment area for the research. I think right now we're less than 50% of the population of the United States participates within a CARES reporting community, and that funding should hopefully expand that and make that hopefully so that every state, every county is participating in it.
Yeah, I mean, I think some of this stuff scientifically seems really simple, right? But it's not. Like, just getting the people in the room is the hardest part, and finding community leaders that they trust to lead a class or welcome in somebody else to lead a class is tremendously difficult. So to have some of that backing would just be tremendous.
Can I give you a story?
Please.
So Brian and I are emergency medicine physicians, and during COVID, we learned a really important lesson and turned it into a community engagement endeavor that correlates really nicely with what we're doing with the Perkins and Dr Foundation and the research arm Brian's leading. So at Roanoke Memorial Hospital in March of 2020, when COVID started, we saw a lot of Spanish-speaking patients that were largely male, largely 20 to 40 age group, largely in the construction industry. And at the time, we were a little puzzled and started asking some questions in terms of why is this particular demographic coming in. And then we realized there was no great access to Spanish language education about COVID in Southwest Virginia. Then we found out a lot of these patients, even if we printed discharge instructions in Spanish, were coming from Honduras, and illiteracy was a major barrier for them. So that also wasn't going to be particularly helpful if we didn't address that issue as well. They had lack of follow-up. A lot of our COVID follow-up was obviously virtual. Who is going to call these individuals? But here presents an opportunity. So seeing this is the social determinants of health, a lot of them all in one space, and how can we address that? So Brian and I worked together, we put a team together and worked with the medical school and students and Bradley Free Clinic. And 12 months later, roughly, we had a Spanish language night at Bradley Free Clinic for patients, specifically engaging those that presented to the emergency department who identified themselves as Spanish speaking, and offering them an opportunity to follow up for free at the Bradley Free Clinic. Well, the first month we had a no-show rate greater than 50%. Second month, a little better. Then, as time went on, we would get patients that no longer we'd contacted, but word of mouth. Bradley Free Clinic became a trusted, patient-centered home in the community for Spanish language patients. And the reason why this is so important is identifying a particular community, their barriers to healthcare, and developing something for them that is very specific for their needs, and really understanding it takes time. That's what we're trying to do as a foundation, going to every learner community. What is it we can deliver that's going to help you start saving lives with cardiac arrest in your community? What will empower you? How can we help you? And then hoping that other nonprofits in the cardiac arrest world will see our model and say, like, this is something we can also collaborate with, and we would love to collaborate with other nonprofits in the cardiac arrest world and work with them in any community throughout the country.
Wow. Thank you for that story. It's huge. It's something that, as a practitioner in the inpatient world, I say goodbye, and I am not a part of coordinating the care outside the hospital. I work with the case managers and the social workers, but that is a really incredible part of the ER's role, I suppose, is you guys mentioned earlier in the conversation that the ER is the front door. It sounds like you guys are maybe creating some side doors and some off-ramps and some other routes to address that need, which probably helps an overburdened emergency room and also gives a much cleaner pathway and maybe a more community-based pathway for folks to pursue that. That's incredible. There's, yeah, wow. Well, if there's folks that are listening, are there ways for them to connect with, the research, Brian, that you're doing, or Jack, what your foundation is doing?
Yeah, so just to be clear, Brian would be the contact for the research piece, and I'd be the contact for Perkins and Dr. Foundation out questions. So if anybody's interested in our educational model in terms of a sister nonprofit in the cardiac arrest world, or in for-profit, will partner with whoever, anywhere in the country or the world for that matter, and wants to say, what's your educational model? How could we collaborate? Just tell us more about you. Then they can go to our website and send us an email, or they can just email us directly at compressandshock@gmail.com. My personal email is jperkins@compressandshock.com. You can email generic, my email, whatever you like. I'd love to hear from you and collaborate. Because we've started having some inroads with collaboration with other nonprofits around the country, and it is just wonderful.
That's awesome.
Yeah, and same. I mean, I'd be happy, anybody, whether you're a student, prospective student, or, you're 70 years old living in the community and just want to get involved, happy to have you. So probably easiest way would be just my personal email, which is Meier, my last name, and then BJ, as in Brian James, at gmail.com, and I'd be happy to hear from you.
Well, we'll definitely make sure we have that written out on the description of the video so folks can be able to reach you. I just want to thank you guys. As somebody that's been in this world for almost 20 years, I am walking away with some new perspectives and new things to think about, and I think that's incredible. There's nothing more that I could hope for.
I echo that. Thank you so much for everything that you both are doing, and the research end of letting us learn more about the populations that need this education and how we can best tailor it to their learning abilities, and then everything that you're doing, Jack, with getting the education out there and getting defibrillators out there and really spreading that word.
Yeah, thank you guys for having us. I mean, I know just getting this isn't my wheelhouse, so kudos to you guys and Ian for having this all set up, because I think making all this known is just as important as doing it. So thank you very much.
Thank you very much for having us. It's a wonderful opportunity, and just always great to talk about it.
Amazing. Thank you so much, and I hope we have you back someday soon. Hear all your next level and all the new things you're doing.
Thank you.
Yeah,
thank you guys
very
so
much.
much.